Hello and welcome, fellow student doctors. Today, we will talk about the cerebellum, which means little brain in Latin. Think of the cerebellum as a coordination center. The cerebral cortex will tell the body to move, and the cerebellum will coordinate that command into smooth movements. If the cerebellum is injured, the patient loses coordination and develops ataxia, which might be the least understood word in medicine. There are multiple types of ataxias, and ataxia goes well beyond just a loss of balance. We will learn about all of this and more, so let's go ahead and get started. To prepare you for test day, you'll be able to 1. Describe cerebellar anatomy. 2. Explain input and output cerebellar pathways. 3. Differentiate forms of ataxia. And 4. List causes of cerebellar ataxia. This diagram will serve as a cheat sheet for the cerebellum. Just as the cerebral cortex has a homunculus, so does the cerebellum. Let's build it together. This area controls eye movements and equilibrium, and is called the flocculonodular lobe. You may also notice a midline region that corresponds to truncal and proximal muscle control. This is called the vermis. Finally, there are 2 outer regions that control the limbs of the body. These regions are called the hemispheres, and they control the ipsilateral side of the body. In general, the ipsilateral cerebellum controls the ipsilateral side of the body. That means that the right side of the cerebellum controls the right side of the body, and the left side of the cerebellum controls the left side of the body. By knowing this homunculus of the cerebellum, you can answer many board questions. Pictured here is the cerebrum above with the cerebellum below that is connected to the brainstem. The cerebellum is attached to each section of the brainstem by cerebellar peduncles, which are fiber tracts of axons going into and out of the cerebellum. The red arrow indicates the superior cerebellar peduncle, which connects the cerebellum to the midbrain, the most superior aspect of the brainstem. The blue arrow indicates the middle cerebellar peduncle, which connects the cerebellum to the pons, the middle aspect of the brainstem. The green arrow indicates the inferior cerebellar peduncle that connects the cerebellum to the medulla, the most inferior portion of the brainstem. Not shown in this image is how the cerebellum and its peduncles help form the fourth ventricle. To understand this anatomy, we need to remove the cerebellum and look at the backside of the brainstem. In this view, appreciate the superior, middle, and inferior cerebellar peduncles and how they contribute to the shape of the fourth ventricle. This anatomy is better shown in this image of the ventricles, with the fourth ventricle being highlighted. Putting the cerebellum back, I want you to understand that each peduncle carries different types of information. The superior cerebellar peduncle connects the cerebellum to the midbrain and provides output to the opposite cortex to regulate movement. The middle cerebellar peduncle connects the cerebellum to the pons and carries information from the opposite cortex into the cerebellum, an input pathway. The inferior cerebellar peduncle connects the cerebellum to the medulla and carries information from the same side of the spinal cord into the cerebellum, an input pathway, which makes sense as the medulla is directly connected to the spinal cord. The output pathway of the inferior cerebellar peduncle involves the vestibular nuclei. We will cover these pathways in greater detail later in the presentation. Here is a horizontal slice of the cerebellum with the brainstem and one of the peduncles labeled. Correlating our homunculus of the cerebellum, the hemispheres controlling the ipsilateral limbs are highlighted in purple, while the midline control of the trunk and eyes are indicated by the pink vermis and green flocculonodular lobe. As we will see, these regions correspond to the cerebellar nuclei, which are responsible for 100% of cerebellar output. This nucleus is outlined in purple because it corresponds to the hemisphere in purple in the diagram above. This represents the dentate nuclei. The next nuclei are outlined in pink, corresponding to the vermis, and are called the emboliform nuclei. Again, the next nuclei are outlined in pink, corresponding to the vermis. These are called the globose nuclei. Lastly, these nuclei are outlined in pink and green, corresponding to the vermis and floccular nodular lobe, and are called the vestigial nuclei. To remember these nuclei and their position from lateral to medial, say, don't eat greasy foods. For dentate, don't, emboliform, eat, globose, greasy, and vestigial, foods, nuclei. It's critical to understand the cerebellar nuclei and their relationship to the overlying cortex, highlighted in yellow, that corresponds to the vermis, floccular nodular lobe, and hemispheres. Here, a hemisphere is highlighted. Essentially, Purkinje cells in the cortex, whether it be the hemispheres, vermis, or floccular nodular lobe cortex, secrete GABA, an inhibitory neurotransmitter, onto their respective cerebellar nuclei to modulate their activity. The Purkinje cells are controlled by granule cells in the respective area of the cortex that secrete glutamate, an excitatory neurotransmitter, onto the Purkinje cells to modulate their activity. These cells are influenced by two types of fibers, mossy fibers and climbing fibers. Making a correlation, the mossy and climbing fibers make up the peduncles, bringing information into the cerebellum, the middle cerebellar peduncles and inferior cerebellar peduncles. The mossy fibers receive information from the cerebrum, spinal cord, and brainstem in what I like to call the flow pathway. Imagine riding a bike. It takes a lot of coordination, the specialty of the cerebellum. And the mossy fibers are critical to the flow of movements and stability required. Ultimately, mossy fibers activate the cerebellar nuclei and granule cells in the cortex that modulate the Purkinje cells in the cortex that project to the cerebellar nuclei. Now, to discuss the climbing fibers, which are fibers arising exclusively from neurons in the inferior olivary nucleus in the medulla. The inferior olivary nucleus receives inputs from many parts of the central nervous system, the cerebrum, brainstem, spinal cord, and the cerebellum itself. This makes up what I like to call the error control pathway. Using the riding the bike example again, the climbing fiber pathway would become activated if you hit a rock and it caused your normal flow of riding a bike to become disrupted. You'd need to correct for that error by re-coordinating your muscles to keep riding the bike. That is what the climbing fibers do. These fibers, like the mossy fibers, are excitatory to the cerebellar nuclei. The fascinating feature of the climbing fiber is that each climbing fiber has a 1-to-1 relationship with each Purkinje cell in the cerebellar cortex. This allows for a powerful influence of the Purkinje cells that directly influence cerebellar nuclei. The cerebellar nuclei complete the communication loop by projecting to the inferior olivary nucleus in the medulla. Overall, you must understand that the cerebellar nuclei are responsible for 100% of the cerebellar output and project to pathways in the cortex, thalamus, brainstem, and spinal cord via the output peduncles, the superior cerebellar peduncles, and inferior cerebellar peduncles. Let's update our cheat sheet by adding in the regions of the cerebellar cortex with their respective nuclei. The Purkinje cells in the cortex of the floccular nodular lobe influence the vestigial nuclei to control eye movements and equilibrium. The Purkinje cells in the cortex of the vermis influence the emboliform, globose, and vestigial nuclei to coordinate trunk stability and proximal muscle control. Lastly, the Purkinje cells in the cortex of the hemispheres influence the dentate nuclei to control the ipsilateral limbs. Before we discuss neural pathways, let's define ataxia, which does not simply mean the loss of balance. It is a huge term. A means without and taxia means order, like taxonomy, same common root. So, ataxia means a lack of order or coordination and is interchangeable with terms such as asynergia and dyssynergia. These terms mean without or abnormal synergy or order or coordination. I feel as students we sometimes think ataxia is synonymous with the cerebellum. It is not. There is cerebellar ataxia, sensory ataxia, and vestibular ataxia. For cerebellar ataxia, there is gait ataxia, where patients have a wide-based, unsteady gait. Truncoataxia, where the patient cannot remain upright. They sway, with their eyes open or closed. Limb ataxia, with subcategories of dysmetria, dysdiadochokinesia, and intention tremors. Speech ataxia, manifesting as dysarthria with scanning speech. Ocular ataxia, where the eyes can exhibit dysmetria, nystagmus, and certain saccades. And tone ataxia, where patients have hypotonia or decreased muscle tone with floppy joints. All of these are forms of cerebellar ataxia as the body cannot coordinate gait, truncal stability, limb movements, speech, eye movements, and muscle tone. We will revisit these terms. Sensory ataxia, such as from vitamin B12 deficiency, is another form of gait ataxia where the patient has a wide-based, high-steppage gait with a stooped posture. They lack the sensations, the proprioception necessary to coordinate gait and stomp with their steps because they do not know where their limbs are in space. Truncoataxia occurs when the patient cannot compensate with their vision to overcome the lack of proprioceptive information. Lastly, vestibular ataxia, such as from vestibular neuritis, manifests with equilibrium and gait ataxia, resulting in vertigo, along with ocular ataxia manifesting as nystagmus. As you can see, ataxia goes way beyond a simple loss of balance and has causes other than cerebellar lesions. Let's differentiate forms of ataxia with the Romberg and Unterberger test. To perform the Romberg test, ask the patient to stand with their feet together, arms out with their palms up, and eyes closed. Make sure their eyes are closed. If the patient begins to sway or their swaying increases, this is a positive result and indicates a sensory or vestibular ataxia. In terms of a sensory ataxia, the Romberg examines the health of the dorsal column medial lemniscus pathway that brings proprioceptive information via the dorsal columns into the primary somatosensory cortex. If this pathway is injured, such as from a vitamin B12 deficiency, the person cannot tell where their body is in space. They lose proprioception. They can compensate with their vision, but when we ask them to close their eyes, they can no longer compensate, giving them a positive Romberg test. It is high yield to know that syphilis causes tabes dorsalis, where there is a loss of the dorsal root ganglia in the dorsal columns, leading to a positive Romberg. The Romberg test also assesses visual compensation for coordinating posture. Patients with vestibular ataxias, such as from vestibular neuritis, also compensate with their vision as they lose their sense of equilibrium, giving them a positive Romberg test. Lastly, make sure you know that the Romberg test does not, I repeat, does not test for cerebellar ataxia. With cerebellar ataxia, the patient has coordination issues and sways with their eyes opened or closed. The sway either begins or worsens once the eyes are closed for a positive Romberg test. The Unterberger test allows us to differentiate sensory and vestibular ataxias by asking the patient to close their eyes, stretch out their arms with their palms up, and march in place for 50 steps. If they march and turn greater than 30 degrees in a circle to the right, they have right vestibular issues. Conversely, if they turn more than 30 degrees to the left, they have left vestibular issues. both findings of a vestibular ataxia. With vestibular issues in general, the patient exhibits ipsilateral signs and symptoms. Here, they do not know where their body is in space and start marching in a circle. The vestibular system is composed of cranial nerve 8, vestibular nuclei in the brainstem, and the vestibulocerebellum, the parts of the cerebellum that coordinate the vestibular system. So this finding may indicate a cerebellar ataxia, the Unterberger test's vestibular function. So it is negative in a sensory ataxia. When approaching an ataxic, swaying patient, start with the Romberg test. If it's negative and the patient sways with their eyes opened or closed, think cerebellar ataxia. If the sway is to both sides of the body, they're swaying left and right, think of a midline cerebellar lesion, such as to the vermis or floccular nodular lobe in their respective nuclei. If they sway to one side predominantly, think a lateral cerebellar lesion to the ipsilateral hemisphere and dentate nuclei. If the Romberg is positive and the patient's swaying begins or increases when their eyes are closed, follow up with Unterberger's test. If it's positive and the patient rotates greater than 30 degrees, think vestibular ataxia. If it's negative and the patient rotates less than 30 degrees, think sensory ataxia. Let's apply what we've learned to some high-yield functional zones of the cerebellum. The cerebrocerebellum refers to the areas of the cortex cerebro that interact with the cerebellum to coordinate motor movements. Overall, the ipsilateral cerebellum controls the ipsilateral side of the body. For example, the left motor cortex signals the right cerebellum, which communicates back to the left motor cortex that controls the right side of the body. There is a double cross. Let me show you. The left motor cortex projects via the left internal capsule to the left pontine nuclei. Fibers from the left pontine nuclei cross over to the right side of the pons to enter the right middle cerebellar peduncle, which communicates, via mossy fibers for example, with the right cerebellar cortex. Specifically, the right cerebellar hemisphere's Purkinje cells that project to the right dentate nuclei. Also, the fibers from the right middle cerebellar peduncle communicate directly with the right dentate nuclei. The right dentate nuclei project via the right superior cerebellar peduncle to cross back over to the left side of the body to reach the left thalamus, specifically the VA-VL nuclei, that project back to the left motor cortex that controls the right side of the body. Now, you can appreciate the crossovers in this pathway that allow for the ipsilateral cerebellum to control the ipsilateral side of the body. Lesions of the cerebrocerebellar pathway corresponds to hemisphere lesions, so limb ataxia findings predominate. This includes dysmetria. Dys means abnormal and metria means to measure. So patients have difficulty measuring the speed and direction of movements. This is examined with heel to shin testing, where the patient moves their heel up and down on the shin of the opposite leg, as well as finger to nose testing, where you ask the patient to touch your finger, then touch their nose. With these movements, the patient will have a zigzag motion of their heel and miss your finger and their nose. Dysdiadochokinesia means abnormal, kinesia, movement. So this refers to abnormal, rapidly alternating movements. This is tested by asking the patient to quickly flip their hand over and over again in their palm. They will not be able to coordinate this. An intention tremor is an action and kinetic tremor, meaning it occurs with voluntary movement, not at rest like the tremor in Parkinson's disease, and manifests as a zigzag motion as the hand approaches a target. This would be seen with finger-to-nose testing for dysmetria, as it falls under that category. This tremor improves with rest. Lastly, While hemispheric lesions mainly manifest with limb ataxia, speech ataxia can also be seen. This creates a form of dysarthria known as scanning speech or staccato speech, where there is a lack of coordination between words. Instead of the patient saying, "How are you?" the patient would say, "How are you?" They are scanning for the words as they are ataxic. They cannot coordinate sentences. The spinocerebellum controls the ipsilateral side of the body as left-sided proprioception from the spinal cord enters the left cerebellum, hence the spinocerebellum name, where output fibers project to the right red nucleus that controls the left side of the body. Hence, the cerebellum controls the ipsilateral side of the body. Let me show you the left spinocerebellar tract, which is damaged in many conditions, such as a vitamin B12 deficiency. The spinocerebellar tract carries left-sided information on proprioception to the left inferior cerebellar peduncle, which provides input via mossy fibers, for example, to the Purkinje cells in the left cerebellar cortex, specifically the vermis. These cells modulate the firing of the left emboliform, globose, and fastigial nuclei. Notably, the left inferior cerebellar peduncle fibers project directly to these nuclei as well. The output message is sent via the left superior cerebellar peduncle that projects to the opposite side of the body to the right red nucleus in the midbrain. These neurons project back to the opposite side of the body to control the left rubrospinal tract that influences the ventral horn motor neurons on the left side of the body to help regulate tone and limb musculature. Yes, some limb control comes from the rubrospinal tract, whose cerebellar nuclei correspond to the midline vermis. But it highlights the point that the double crossing in these pathways leads to ipsilateral cerebellar control of the body. The key takeaway is the second output from the left inferior cerebellar peduncle that projects to the bilateral ventral horn motor neurons. This corresponds to the reticulospinal tract, whose bilateral projections to motor neurons allows one side of the cerebellum to control two sides of the body, a key role in truncal stability. If you are sitting, the left and right back muscles maintaining your truncal stability receive input via this pathway. These pathways correspond mainly to the vermis and underlying nuclei that maintain truncal stability and proximal muscle control. So midline cerebellar lesions in the vermis and nuclei manifest mainly with gait and truncal ataxia. The patient will have difficulty coordinating heel-to-toe gait movements and will sway with their eyes opened or closed. A negative Romberg test that indicates a cerebellar cause of ataxia. The last functional division we'll discuss is the vestibulocerebellum. This pathway begins with cranial nerve 8, the vestibulocochlear nerve that projects to the vestibular nuclei in the brainstem. From here, input fibers, mossy fibers for example, travel via the left inferior cerebellar peduncle to Purkinje cells in the left cerebellar cortex of the floccular nodular lobe that influences the underlying fastigial nuclei. Notably, the left inferior cerebellar peduncle inputs directly to the fastigial nuclei as well. Overall, the fastigial nuclei project via the left inferior cerebellar peduncle to two pathways. The first, in blue, goes back to the vestibular nuclei, then to cranial nerves 3, 4, and 6 nuclei to control eye movements. The vestibular nuclei also project to bilateral ventral horn motor neurons via the vestibulospinal tract for coordinating muscles involved in truncal stability. The second pathway travels via the inferior cerebellar peduncle all the way to the bilateral ventral horn motor neurons. These fibers, like those from the spinocerebellum, help form the reticulospinal tract, a critical pathway for truncal stability. The vestibulocerebellum pathways correspond mainly to the floccular-nodular lobe and vestigial nuclei for control of eye movements, equilibrium, and truncal stability. So midline lesions result in gait ataxia with abnormal heel-to-toe testing, truncal ataxia that can cause head tilting, which occurs because eye movements become less coordinated, so the head tilts via the neck, the trunk, to adjust for the abnormal positioning of the eyes. The patient may experience ocular ataxia with ocular dysmetria. Imagine watching a bird fly to the right and then to the left and then to the right, where it stops to perch on a branch. The eyes should track this smoothly. In ocular dysmetria, the eyes will move too far left and too far right, back and forth before finally settling on the perched bird. Central vertigo can also occur with vertical or up or downbeat nystagmus that does not, I repeat, does not correct with fixation. This contrasts sharply with peripheral causes of vertigo, which have horizontal nystagmus that does correct with fixation. In terms of causes of cerebellar ataxia, there are hereditary cerebellar ataxias, congenital cerebellar malformations, acquired causes of cerebellar ataxias, and cerebellar tumors. Pause, read over these, and we will discuss some examples in the coming slides. Friedreich's ataxia is an autosomal recessive, hereditary ataxia that is a trinucleotide repeat disorder that leads to decreased levels of frataxin, an iron-binding protein that causes mitochondrial dysfunction. Think about it. There are a lot of redox reactions occurring in the mitochondria with iron-binding proteins. With dysfunctional mitochondria, organs with increased metabolic demands become affected, such as the nervous system, heart, and pancreas. Starting with the nervous system, there is degeneration of the dorsal columns, leading to decreased proprioception. Degeneration of the lateral cortical spinal tract leads to spastic paralysis and upper motor neuron signs. Lastly, degeneration of the spinocerebellar tract affects the spinocerebellar pathways we covered earlier, resulting in cerebellar ataxia. The heart also has a tremendous metabolic demand, and patients develop hypertrophic cardiomyopathy, a very high-yield fat, along with pancreatic dysfunction, which requires a lot of energy for insulin production, so patients develop diabetes mellitus. Lastly, skeletal anomalies include kyphoscoliosis, pes cavus, and hammer toes. The second hereditary ataxia to know is ataxia telangiectasia, an autosomal recessive disease with the perfect name as the image shows telangiectasias, or small dilated capillaries. This is an A disease, as ataxia telangiectasia is an autosomal recessive disease due to a defect in the ATM gene that causes spider angiomas, antibody deficiencies, leading to immunodeficiency, characteristic AFP elevations, cerebellar atrophy, ataxia, sensitivity to radiation, DNA damage, and an increased cancer risk. To understand congenital malformations, you must understand the cerebellar tonsils, which are outpouches of the cortex shown in the sagittal image at the top and the inferior view of the cerebellum at the bottom. These tonsils are abnormal in Chiari malformations, which are posterior fossa, where the cerebellum sits, defects. In a Chiari type 1 malformation, the cerebellar tonsils are herniated, indicated by the arrows, leading to a headache that is classically worsened by coughing. The patient may also have syringomyelia, a syrinx, a cyst in the spinal cord. In a Chiari type 2 malformation, the cerebellar tonsils, vermis, and medulla herniate through the foramen magnum, causing non-communicating hydrocephalus by obstructing the fourth ventricle. Patients with a Chiari type 2 malformation classically develop a myelomeningocele as well, this is a form of spina bifida. On test day, if you see a patient with Chiari type 2 malformations, look for a myelomeningocele. If you find a patient with a myelomeningocele on test day, evaluate for Chiari type 2 malformations. That is so high yield, I know it will get you a point on test day. Please know that fact. I remember these two conditions by imagining grabbing the spinal cord and pulling down. First, the cerebellar tonsils would herniate, a type 1 Chiari malformation, and where my hand touches would represent the syrinx for syringomyelia. If I pulled on the spinal cord even harder, the cerebellar tonsils, vermis, and medulla would all herniate through the foramen magnum, a Chiari type 2 malformation. Lastly, if you imagine pulling so hard that you rip the entire spinal cord out of the spinal column, that would represent a myelomeningocele in a type 2 Chiari malformation. Lastly, a Dandy-Walker malformation is characterized by agenesis of the vermis with cystic enlargement of the fourth ventricle. The fourth ventricle is normally located outside of the posterior fossa where the cerebellum sits. That's why this is called a posterior fossa defect. In terms of acquired causes, alcoholic degeneration of the cerebellum occurs with long-term alcoholic consumption. Ethanol is directly toxic to the vermis of the cerebellum that is critical for truncal control. This is not, I repeat, not due to thiamine deficiency. Alcohol, ethanol, is the toxin. Essentially, alcohol is toxic to Purkinje cells specifically in the vermis, so patients present with a wide-based, unsteady gait, that is, gait ataxia. Ethanol is a GABA receptor agonist that causes hyperpolarization of Purkinje cells. Therefore, when people drink alcohol, they get wobbly. They are literally poisoning the cerebellar vermis. With long-term alcoholic consumption, the gait ataxia is usually irreversible. Post-infectious cerebellitis or inflammation of the cerebellum classically occurs in children days to weeks after viral infection or some vaccines. They present with rapid onset cerebellar ataxia. That is how you will identify it in a board exam. It is a rapid onset cerebellar ataxia that is usually self-limited. Lastly, one type of brain herniation syndrome is the cerebellar tonsillar herniation, highlighted in red, through the foramen magnum. Strokes can also cause cerebellar ataxia. Ischemic strokes to the vertebral and basilar arteries that feed the superior, anterior inferior, and posterior inferior cerebellar arteries can occur, which correlate to blood supply for these highlighted regions. Overall, look for brainstem signs and symptoms along with cerebellar ataxia findings as the blood vessels transverse the brainstem to reach the cerebellum, as you can see in this diagram. Lastly, hemorrhagic strokes in the cerebellum due to hypertension can also occur as indicated by the red arrow. Tumors that form in the cerebellum in children and adults can also cause ataxia. The most common childhood brain tumor is a pilocytic astrocytoma that stains positive for GFAP, glial fibrillary acidic protein, because it's of astrocyte origin and astrocytes are a type of glial cell. Histologically, this tumor has bipolar cells with hair-like extensions, microcysts, and Rosenthal fibers, eosinophilic, corkscrew-shaped fibers indicated by the blue arrow. These tumors have a good prognosis, whereas medulloblastomas sadly do not, as they are the most common malignant tumor in children, a primitive neuroectodermal tumor characterized by Homer-Wright rosettes, blue arrows with cells that stain positive for synaptophysin. Ependymomas form in the fourth ventricle and compress the cerebellum with characteristic pseudo-rosettes of cells around a blood vessel. Lastly, Hemangioblastomas form in the cerebellum of adults, especially those with von Hippel-Lindau disease, an autosomal dominant disorder due to a loss of the VHL protein that regulates hypoxia-inducible factor. Without this regulation, the body thinks it's hypoxic and forms highly vascular tumors in the retina, brainstem, cerebellum, and spine called hemangioblastomas. Use the mnemonic HARP to recall the features of von Hippel-Lindau disease, with the H for hemangioblastomas, A for angiomatoses, R for bilateral renal cell carcinomas, and P for pheochromocytomas. Alright friends, it's time for a flash quiz. The question reads that a 60-year-old man with a history of hypertension and hyperlipidemia presents to the emergency room with chest pain. During evaluation, he develops cardiac arrest and becomes pulseless. CPR is performed. After 5 minutes of resuscitation, he has a return of spontaneous circulation with pulse and blood pressure readings normalizing. Which of the following structures was likely damaged? A. Dentate nucleus. B. Vestigial nucleus. C. Mossy fiber. Or D. Purkinje cells. The correct answer is D. Purkinje cells. During his cardiac arrest, there was global ischemia of the brain. While all neurons are extremely sensitive to hypoxia, Purkinje cells of the cerebellar cortex and pyramidal cells of the hippocampus are amongst the most sensitive to hypoxia. Remember these two cell types, Purkinje cells of the cerebellar cortex and pyramidal cells of the hippocampus, as at least one of them in this exact question format will be on your exam. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. Use the homunculus of the cerebellum we built during the lecture for a high-yield review of cerebellar function. Always remember that the ipsilateral cerebellum controls the ipsilateral body. That is, the right side of the cerebellum controls the right side of the body, and the left side of the cerebellum controls the left side of the body. Know that ataxia means uncoordinated movements with cerebellar, sensory, and vestibular causes that can be differentiated by the Romberg and Unterberger tests. Lastly, know that there are hereditary, Friedreich's ataxia, congenital, Chiari malformations, acquired, strokes and alcoholic degeneration, and tumor, pilocytic astrocytomas in children, hemangioblastoma in adults, causes of cerebellar ataxias. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always, always, always remember, there is a great big beautiful tomorrow.